can I thank both the Fabians and the North Melbourne branch for having chosen health as the topic for their Fringe event. It is such an integral part of our social fabric and allows the opportunities for people to participate in our social and economic life, and it is critical to not only the Labor Party's policy platform but obviously to the nation. So thank you for picking what I think is the most important topic of policy for your Fringe event. Can I also acknowledge that I have with me as well Senator Jan McLucas. I have a fantastic shadow ministerial team of people who are all doing different things in the health portfolio. Jan has responsibility solely for mental health. We felt it was very important in government. Obviously, we had a Minister for Mental Health. We think it is an area that does require a separate ministry of someone who is dedicating their time, energies and effort to doing that. And Jan in our show is the Shadow Minister for Mental Health. I'm not sure, I think there are also delegates today, but Nick Champion is the Shadow Parliamentary Secretary for Health, and he's doing work on palliative care and also on health workforce. And I also have the Shadow Assistant Minister for Health, and that's Stephen Jones, who is doing some great work for me on drug and alcohol services, as well as all of some of the very complex regulatory agencies that go along with health as well. So thank you very much for having me here this morning. I also acknowledge a lot of my staff are here today. They've been working pretty hard on some of the Fringe events, as well as my personal staff on some of the policy areas as well. I thought what I'd do is just talk very briefly just a little bit about some of the history of health reform in Australia and where we're up to now. And the reason I want to do that is because often when we look back over or we look at what we want to do with the health system, we have a very long conversation with people about, well, if only we didn't have a federated health system, if only we had one payer, if only we had one level of government responsible for service delivery. And to some extent, the reason that we have all of the complexities of the system we have is really because of our history. It's the way in which our health services have developed, it's the way in which our federation has developed. And to some extent, the debate that we have around who's responsible and where, we've had lots of them. And lots of those conversations do start with if only, if only, if only. And I come at it from the perspective to say that yes, those debates are really important and we've got to continue along that pathway, but really what we've actually got to start to do is work with what we've got to actually make sure that we have the patient at the centre of everything that we do, and how do we get a system that works that way, rather than constantly talking about who finances and what level of it finances it. So I want to talk a little bit about that first and then talk about where we're up to. Obviously, in terms of the history of health reform, there's been some very big phases, and of course the largest was post-World War II, when we had the first debates around actually having a very big national role for funding public hospitals, the first pharmaceutical benefits scheme, again both Labor initiatives to start that. The first agreements with the states and territories around hospitals were Labor initiatives, and of course leading all the way through to Goff's Medibank, an incredibly huge reform, which I acknowledge the Doctors Reform Society, particularly in the second iteration of Medicare, had a huge amount to play and were very critical to us and able to if not bring the medical fraternity with us, certainly have them participating in the debates very actively. Obviously Medibank, then Medicare, two very huge parts of reform, but of course reform didn't stop there. There were two very major pieces of work done under the Hawke government when Brian Howe was with us as well, where we had Jenny Macklin's National Health Strategy. I'm not sure if people remember that. Some of us are still lucky enough to have those papers, but again, there was a huge piece of work done looking at where are we with health, what do we need to do, and those papers still exist and are important today. We then had, under the Gillard and Rudd governments, again a major period of health reform where we had a Health and Hospitals Reform Commission, and we spent a year going around the country looking in great depth and detail about what were the problems in health right the way across the system. We had a National Health Prevention Task Force who developed a National Preventative Health Strategy. We had a huge amount of work done in primary care, and obviously also in public hospitals, and mental health was also a very big focus of our reforms. Unfortunately, where we are at today is that largely the Abbott government has literally unpicked every single one of those health and hospitals reform. I've never seen a period of time in health policy where we are at such a dearth of national complex thinking about where we are going to go. And we've seen some of the most regressive policies. So literally, I'll go through them carefully, but in prevention, overnight, the national partnership agreements with the states and territories on prevention were basically gone. So not only is it the money, it was what that money was actually doing in communities right the way around the country. The abolition of the National Preventative Health Agency, the first time we actually had a national authority legislated to actually work towards providing and building the evidence base for preventative health, undertaking research work, being a clearinghouse for all of the preventative health work that was happening in this country, and sort of pushing the envelope a bit on where we might go nationally on prevention. Overnight, pretty much all of that gone. Then we had the attack on primary care, again around funding mechanisms. So you will start seeing, if you haven't around your communities, GPs changing their billing practices already, and a lot of them dropping bulk billing, so we're going to see a very significant impact on bulk billing rates. Then what of course we've seen is the ripping up again of the agreements that we negotiated with states and territories on public hospitals, and a change to the funding formula that will come into effect in 2017, which is in essence taking a large amount of money out of public hospitals. But it's not just the money that is the issue, it's actually the reform agenda and the agreement that we have, that the national government, alongside states and territories, would have an agreement about how we actually get public hospitals to be more efficient, but also to really focus on quality care. So that went overnight as well. There were attacks on dental care, attacks on mental health, large amounts of money taken out of funding for not-for-profits. The architecture of primary healthcare reform, Medicare locals, again has gone with new primary health networks. So literally there isn't an area of health policy that the Abbott government didn't come in and basically trash. Not only, and for no good reason, I'd have to say. I think what they've done, they didn't have a vision of health policy, didn't actually have an idea about what it was that they were seeking to achieve, and in essence have just gone about trying to destroy everything because it had a Labor name associated with it, rather than actually fundamentally changing or pushing the envelope with health reform. So that leaves us to where are we now? We've lost 2 years of very good and important health reform. Everybody is now calling out for health reform again, but are also, what you've seen the Abbott government is to conflate health reform with health financing, and that is all they seem to be talking about is health financing, not what is it that you actually want to do. So going to the question of the actual forum here today about is it possible towards equality, can Australia have a healthy future? I'd say yes, we can. The reason we do have some of the best health outcomes in the developed world is because of our primary care system. And primary care is going to be the key. Primary care, particularly general practice, but not just general practice. General practices, I often talk about having a much more integrated role alongside other primary care professionals and making sure that we actually do have better integrated care. Primary care has to be the focus and core of all that we do in our health, the main focus of what we do in our health policy going forward. And the reason I say that is because we know that all of the literature will tell you that the stronger your primary care system, the better your health outcomes are. So the issues that we have with primary care obviously are multiple. There are issues of access, and particularly continuing access in a whole range of communities for Aboriginal and Torres Strait Islander groups, for rural and regional communities, for people in outer metropolitan areas, so access has to be a focal point. What primary care does, and the financing mechanisms obviously do also need to be a focal point of any policy development, and that word integration. We've talked about integrated primary care for a long period of time, but what does it mean and how do you actually get it? How do you get that seamless approach between our public hospitals and our residential care? So that's been a focus of our policy development. Prevention, again, has to be at the heart of our policy as well. And it's hard. We've done really well with tobacco, not so well with alcohol, not so well with obesity. particularly on obesity, building the evidence base of what actually works and how can we get that out into local communities. And we've got a long way to go, but I think that if we don't have that as our focal point back again, then we really will be behind the eight ball again. Obviously, hospitals and the provision of services in our public hospital system also has to be a core of what we do. And we're in the process of talking to our state colleagues about what that might look like. But again, we need to focus on hospital reform. I believe very strongly that the Commonwealth must have a role nationally involved not just in funding hospitals but also in hospital reform. And that has to focus around the area of integration. How do you get preventable readmissions? How do you get better quality within your public hospital system? How do you get that integration between our residential aged care or aged care system and our primary care system? So again, a really important focal point. All of those, of course, are underpinned by a focus on health inequality. What do we need to do for those population groups that are not able to access services, or because of the nature of the conditions that they have or the circumstances that they're in? How do you actually make sure that you're providing services for those people and actually lifting? And of course, the largest of those we focused on in government was the closing the gap. It has been an absolute, again, one of the areas in health to watch. The ripping out of money for Aboriginal and Torres Strait Islander health services programs that were working in smoking cessation in particular, but also to see that they've wasted 2 years. Again, we developed with the community a terrific Aboriginal and Torres Strait Islander health plan. It has taken the government, I think, over 2 years to get anywhere near talking about the implementation of that. I understand that might be coming soon, but this is 2.5 years that you have completely lost momentum in this space. So again, pretty disappointing, but again, that's an area. So they are the sorts of things that we're working on and thinking through, but really at the heart of it for me is if we are going to tackle health inequality, primary care and prevention have to be at the core of that. And we're working on policies right at the moment to take that into the next election. I might leave it there and let Tim talk for a bit, and then I'm very happy to engage and answer questions. I think that's the better part of these forums, is when you can actually have those conversations with each other. But thank you for having me here this morning.
Thanks very much. Thank you very much for inviting me. It appears that, as I'm not from the AMA, this is a gathering of fringe dwellers. So, Joe Hockey said that if you wanted to buy a house, you needed a good job. Go and get a good job, you'll be right. He could have been talking about the Coalition's approach to the health system. If you want good health, get a good job and you can buy your health care. That's fine. So, with respect, I disagree with Catherine on the point that we haven't seen that the Coalition doesn't have a plan. They have a plan. It's very clear. It's very clear what their plan is. They believe that those who have money deserve better health care than those who don't, irrespective of the reason. And they will pursue that and have pursued it relentlessly. They have at times overstepped the mark, very much so last year, but they overstepped the mark back in John Howard's time as well, when the bulk billing rate dropped down to 68%, and there was electoral concern, and they were facing defeat at the 2003-4 election. So Tony Abbott came in and gave doctors a $40,000 pay rise through increasing the rebate, and took that issue off the agenda. They're prepared to step back, but they're going forward, and they're succeeding. So that's their position. It's straightforward, to me anyway. So today we need to look for an alternative. And my question today is whether the ALP has the alternative. I'm absolutely delighted with Catherine King's and the party's fight back against all of the ripping apart of the program that they had set in place. Absolutely. And we're fully supportive of virtually everything that has been said, and we'll continue to come out strongly about that. Okay, but if Labor were to win office and get re-elected and reinstitute all of those wonderful things that they had planned, where will we be? Is there still work to be done? Does Labor have the commitment, really, to the extra policies needed to repair and improve our health system? I'd like to narrow down on two issues about this. The first is the GP tax and co-payments. When the GP tax was originally put forward by Joe Hockey in the budget last year, I think I recall that Penny Wong came out and said, this is a tax on illness. Well, we were in total agreement. It's now referred to generally by the Labor Party as the GP tax. And the reason, probably, is that Labor is internally quite conflicted about co-payments, about the tax on illness. Because all we have to do is look over at the pharmaceutical benefit scheme and see that there's a $36 co-payment imposed by the government, or $6 if you're a pensioner card holder. It's there. It is a tax on illness. If you are well, no payment. If you are unfortunate enough to be sick, you're taxed. But the Labor Party, when asked, the Health Minister from some years ago, when asked, well, why don't you address this particular tax on illness, told me that there were budget constraints. Now, I have a bit of trouble with that. There were indeed budget constraints, but when you see that Arimidex, a tablet that is used for breast cancer, costs $90 to the government here in Australia and $3 in the United Kingdom, you wonder why we aren't saving a little bit of money in the PBS to allow for reductions in co-payments, taxes on illness. If we look at the statins, those cholesterol-lowering drugs that half the world is on, I think, if we look at those, we find that in a small country like New Zealand, they pay about 1/10 of what we pay. We are not paying world market prices for drugs. There are savings in the PBS, but also in a lot of other places within the health system, which would stop us putting a co-payment, a financial barrier on care. The Commonwealth Fund is a Harvard-based research institute, and it does surveys of Australians and people throughout the world, and it consistently shows that 20% of sick Australians delay or don't fill out a prescription because of financial barriers. These are ones imposed by government. And as well as that, there are the co-payments. So what we have out there is a fee-for-service system which allows us to charge what we like. And the Labor Party doesn't have particular policy to limit that in any way. I know it's constrained constitutionally and all of those kinds of things, but there are other ways of doing it. We have salaried doctors in hospitals. They don't get co-payments. We can have more salaried doctors in hospitals if we choose to pay for them. We can have salaried GPs, but we choose not to. Anyway, so that's the co-payment issue. Enough of that, except that whilst the second issue that I'd like to talk about basically is access. And I've talked about access to GPs, there's a financial barrier, access to specialists, financial barrier, not the choice of government directly, not imposed, it's up to us kind-hearted doctors to decide how much you pay. We are, of course, very lovely people who have your interests totally at heart and are not at all interested in having a second house at the beach. Reality is different. Reality is different, and we know that if doctors who also are a broad spectrum of people just like the Labor Party, if doctors are allowed to charge co-payments, then they will. Okay. The second issue is hospital access. Now, what's happened over 30 years, we've had private hospitals years ago. When I was training, or when I was a registrar, we had private hospitals. They were small. We had private beds in public hospitals. We had a completely different medical setup because most people didn't have significant surgery in private. They went public because that was where the technology was. It's changed completely now. We're now doing so much more, so much faster, and we have this burgeoning private hospital system, and we now have 60% of elective surgery done in private. Okay, why has it happened that so much is happening in the private system? When John Howard came to power, private health insurance had dropped to 30%. Coverage had dropped to 30%. And the main reason that had happened was because we had a strong public health system and people were just saying, why would I bother? What a waste. I don't really need the view over the park to get better. I don't really need the fancier food. I'll just give it up. And then changes were made. And if you think it was the private health insurance rebate that made the difference, you're completely wrong. It wasn't. That didn't work. They had to do more than that. So what they did was they also stopped you joining for a year to get an operation, the lifetime health cover it's called. They changed that, but at the same time they funded an advertising campaign to make people feel insecure without it. And then over the ensuing years of the Howard government, they dropped the federal government's contribution proportion of hospital funding, public hospital funding, from 52% to 39%. And Labor came to power and said, this is not right, we've got to change it. So they did. They put more money into public hospitals. Unfortunately, when they left, it was still pretty low. It might have been 40 or 41, but it wasn't much higher. But the plan was to increase it, absolutely. And the plan was to increase it by saying 50% of funding, we will guarantee 50% of funding to the states. New funding. No change to old funding. Well, there had been, but then no overall change. What this relied on, and I know there were financial constraints and there always are, what this essentially means is that it will take until 2030 before the federal component on this program, the Labor's program, it will take till 2030 to get to approximately 46%. Not even back to where it was when the Howard government came to power. So the cash-strapped states are really struggling. And what do we see? An erosion of confidence in the public hospital system. Part of it due to the reality that it takes a long time to get an operation, or even to see the surgeon to get booked for an operation. And part of it is also due to the fact that, whoops, I've lost my train of thought. Part of it's due to that. And the other, we'll just leave that for the moment. So we have a problem here that the Labor Party's policy is not going to restore that funding and that perception. So that's it. The perception that the care in public hospitals has also been eroded. The care in public hospitals is as good as private has been eroded. It's not true. The reality is that the wait is longer, but the care in public hospitals remains as good or better than private hospitals. Yeah. Okay, that's true, but there's a perception out there otherwise. So we've got a problem. And what's happened? Private health insurance goes up and up and up. It goes up even despite the Labor government means testing. It's nothing to do with how much it costs to get insured. That percentage is the same. It goes up, premiums go up, CPI, greater than CPI almost every year since it was instituted. doesn't change, still going up. So, what does that mean? It means we have a two-tiered system of access to elective surgery. And the only way to alter that is to have a system, a public hospital system, that erodes people's belief in wanting to go private. Are we going to get there if it's going to take till 2030 to restore federal component of hospital funding up to 46%? I think in 5 years' time we'll have the same problem. And I'd like to just briefly point out the policy document that I understand is approved for health, the framework that was approved just yesterday here at the meeting. States, whilst government have sole responsibility for managing the public health sector, they should also support a strong and sustainable private healthcare industry. Well, if we do that and the public system isn't up to it, we have a two-tiered system. There is another line in the policy. It says, ensure all necessary services are provided in the public health system. That would be great if it also included the word ensure timely access to all necessary services is provided in the public system. It doesn't say that, and we haven't got it. And with the policies that I have seen to date, and the policies of the previous Labor government, we weren't going to have it. So we do have a problem. I sent this document, the Labor Party policy platform, around to my members just the other day, and I said, this isn't really what we need. It's not really as good as we need. And I got a reply. I was feeling down, but this lightened my heart. He said, there may be a dead glowworm on the hill, but that is about as light as it gets.
Well, at this point in time, would you like to perhaps respond? Or no, not that particular one, but just generally, were you going to move on? We've just got to...
I've just got one line
yes,
to put in.
Thank you.
I'm actually an optimist. I wouldn't be in this if I wasn't. And I think that the glowworm is alive, and I'm praying that it will reproduce.
In our survey, one of the highest ranked priority was for preventative health. And there was no doubt about that. There was a little bit of a gap, and then mental health, again, a big priority for people, public subsidies of medications, and of course treatment of chronic illness and domestic violence education. They were the 5 top ranked priorities, but preventative health was definitely well and truly out there. Now, one of the things that Tim has gone to discussion of, and I'm sure that party members and others would be most concerned about, is that there is quite a bit of response in our surveys to the role of the pharmaceutical industry and the part it plays in our health system, and as well as the trade agreements that we may be engaging in, and the impact that that may have on, again, the prices of medications and whatnot. Now, in our survey, we asked, what role do you think the pharmaceutical industry should play in informing health policy and research? And 80% of respondents said less, much less. What role do you think communities should play in health policy formulation? 83%. But that tells us that people really want to control their destinies, and that they are very concerned about not handing that control across to the health industry. And so my question first of all, to Catherine is, will the foreshadowed, for example, Trans-Pacific Partnership really impact on the prices of public subsidies of medications and so forth?
Look, we of course don't know what is in the TPP. It is being negotiated in secret, and the only the information we have access to is obviously what's made its way into the public domain. So we don't know what the final document will look like. The sorts of things from a health perspective that I am concerned about and will be arguing the case that we need to look at the document very carefully is obviously there are several areas where the TPP may affect both pharmaceuticals. So the pharmaceutical industry, so I understand, are very keen to, there's a thing called data exclusivity. They're very keen to extend the period of time by which they can benefit or get the benefit of their innovative drugs, and that means it makes it very difficult for us when they come off patent. It actually costs us less when we have more generic drugs into the system. So obviously that is an area that we are very concerned about. We're also concerned about the investor-state dispute settlement clauses and what that may mean in terms of any preventative health activities. Obviously, plain packaging becomes one of those, but the area of prevention obviously can potentially become very vulnerable with those investor-state dispute settlement clauses if there are things that you do that obviously affect the profitability of companies. So again, we are, you'd be aware that that was one of the major sticking points when we were in government, is that we didn't want agreements with those clauses in them. This government has taken a very different approach. We will be looking very carefully at the TPP. I've heard rumours that it's, and you saw in the paper today, that it's to be signed soon, whether Australia does or not. I know the pharmaceutical benefits scheme and the impact of that was remaining one of the sticking points, but until we see the document, it's very difficult for us to then say one way or the other what it is. But certainly those are the two areas in particular that I'll be looking at, and obviously making representations to Penny Wong, who has carriage of it in the trade portfolio area, as to why we should or should not support such a change. I don't want to see the pharmaceutical benefits scheme and access to medicines become any more expensive or difficult for people. And if the agreement does so, then it's certainly something I will be advocating that we shouldn't support if it contains those sorts of clauses.
Thanks. I'm Mary Draper. I'm a long-term participant in the consumer health movement, and that's what my question is about, how we see this reflected in policy and at the heart of policy. So you talked about the patient at the centre of care. And from our point of view, it's the active participating patient.
Sure.
So if we can sort of think of just two things that in a sense, we know that people who participate in their healthcare do better. We know there are many things that need to change for that to happen. We know that as there are social determinants of health, there are social determinants of participation. So there's a lot to do at that level. And then recently we saw the debate about the illness tax take place between the AMA and the government, and the people who were actually going to bear the cost that were being pushed onto them, that voice was silent in that debate. So the question is, in a sense, what can Labor do to really embed at the heart of policy something about the democratic participation in health?
There's been coordinated veterans care. They're not really been trials. It's actually been work that was started out of a movement really to look at how you could assist better Vietnam veterans and alcohol usage. But the coordinated veterans care trial, in essence, is done. There is an enrolment of veterans with their general practices. There is a payment made to general practices on the basis of how many they've got enrolled. There is some training that's undertaken with those practices. And then there is a very comprehensive care plan developed, but it is literally a care plan that is developed with the patient. And the model that they've used, which Flinders University, if you get online, it's really worth having a look at some of their evaluation of that, really is about that. It is literally the patient and the doctor both agreeing what is it that you are both going to do and commit to doing to actually improve the care. And it can include things like housing. It has included things like drug and alcohol issues. It's much gone much beyond the sort of relationship or some of the relationships you see in not Tim's practice. I know Tim practices very differently. We'd love to see lots of practices that are like how Tim does, but much more broadly. And it's had some pretty good success, some good outcomes, both from health outcomes, but also in terms of how patients are describing the experience of actually being very much in control of what's happening to them. Obviously, it's only a small cohort of patients, but I think it is that sort of work, really practical, on the ground, training people differently, thinking differently about how you actually do care planning, because unfortunately what we do have, whilst we do have an MBS item already for care planning, it really is to some extent not necessarily that integrated relationship, and it's not necessarily then taken forward when you actually see what happens with patients. I think there is quite a strong move to, so things like, at the moment the NHMRC doesn't have a lot of consumer voices in it. I'd like to see a bit more there. There's been moves which I think the government has done, which I support, of trying to get more consumer voices into the Pharmaceutical Benefits Advisory Committee processes. So it has to just be one of those things that you keep thinking about as either Shadow Health Minister or Health Minister, and trying to provide as many opportunities as possible, but also the way your system is designed also has an impact on that. And I'd encourage people to have a look at the Coordinated Veterans Care. Tim might have a different view about that. But
So I think that, no, I'm quite happy with what you said, except one of the barriers to coordinated care and therefore to giving consumers or patients the capacity to be involved is fee-for-service medicine. It just locks people into a time constraint. Now, I mean, you've got the doctor who's paid fee-for-service, and you want to talk to the physio who's paid fee-for-service, and somebody else who's paid fee-for-service, and you might have a salaried nurse. You've got to get them all together. And a lot of that time they're not paid for it. Now, you can give them a separate chunk of funding to kind of facilitate that, and that's half good, but you're still up against it. And I think that that's an ongoing barrier to optimising exactly what we're talking about.
My question is, what will Labor do to give more Australians access to dental care under Medicare?
when Medicare was established, there was obviously a discussion at the time to bring dental care into that, but I think it would be fair to say there was a fight with the doctors over that part of the component. I think there were some decisions taken, perhaps taken on the dental dentist at the same time. Tim will remember the history of this a bit better than I do. Perhaps was a step a bit too far, and we concentrated on one area and didn't do that. It was a missed opportunity, I think, at the time, but we are now 30 years down the track, and we've had a lot of history in terms of trying to get the Commonwealth engaged in dentistry. Every time we've done something, every time the Libs come into power, they literally undo it. So we had the Commonwealth Dental Scheme at one point. We then had our partnership agreements. What so far has survived the change of government, the national partnership agreements on dental haven't necessarily survived. There's been cuts in funding to those. They were largely around expanding the provision of public dental care. The Child Dental Benefits Scheme, I think, which was the result of finally convincing the Greens to allow us to means test the private health insurance rebate. That took a long time to get that through, and it is Labor's policy. I think the Greens like to try and claim credit for it, but Tanya Plibersek, my predecessor, absolutely was fair policy. That what that meant is that, and that entitlement state, I think if the government has its way, I've heard them making noises about their concerns about the Child Dental Benefits Scheme. I think if they had their way, they'd like to get rid of it or shrink it back. We're pretty determined to oppose that if they do any measures of that. So it is a start, and I think that it is certainly, as we have said in the platform, it is a principle. We would like to see fairer and better access to dental care. Whether, again, you did it through Medicare is the problem, because it then lends itself to all of the issues around fee-for-service payments, potentially, that we are currently grappling with. So whether you did it through there, or what we were trying to do is look at, with the bucket of money that you have available, how do you try and actually tackle some of the most vulnerable communities that you can. Children were important. If you looked at the rate of the latest institute, of health and welfare information, the rate of dental caries amongst children had just been skyrocketing, so trying to get that early area, the teen dental checks. One of the areas we think that is still missing is obviously with older Australians, and particularly older Australians in poverty. So we'll look at policies around that. I think it's going to take a while before we have some form of universal dental health cover, but it still remains an aspiration within the party and the platform.
Tim?
My understanding is that they've frozen the rebate.
They have frozen the Medicare benefit schedule rebate, which of course has also impacted on the child dental benefit scheme as well. So yes, that has absolutely had an impact on them as well. So they've done it by stealth, basically.
Can I push the thinking a little bit further into the future, where we've got major demographic changes, and that's not simply ageing population, because there'll be a healthy ageing population, although possibly more impoverished than most of the baby boomers expected to be, but a growing inequality amongst the young. All our imaging and pathology has been privatised. We've lost our pathology labs in hospitals. Our pathology and imaging is what's really driving up costs at the 7 to 8% per annum, and that's now extraordinarily lucrative, and it's the taxpayers who are also aiding that money making. To make it worse, they're taking the work overseas and sending a lot of pathology work internationally, so we're not even employing our own bench scientists to do that work in Australia. Now, these are going to be the big barriers, are in fact the entrenched vested interests of the medical profession. At the same time, we have a younger generation of doctors, many of whom do not want to work full-time, even though the state has invested hugely in their education, and who would be better off as salaried doctors, but who are working shift work, and the far more patients they see, even in a community health centre, the more money they make. So we've actually got some serious endemic moral problems within the profession itself, and how long can we ask the Australian people to keep subsidising medicos to have expensive training and be very well paid? Now, I don't mean people like Tim, obviously, but their rewards are far in excess of what we can afford as a nation. And so finally, can I whether we should think about that when we're talking about health as Labor people, that we talk about it as collective insurance, that we don't resent paying housing insurance and own our house all our lifetime that never burns down. Your taxes for your health are the same thing, and even private hospitals and all private medicine are parasites on the public system, on the universities, on the entire infrastructure that's provided by the public purse. And it's time that we actually put to the forefront the critical role the public purse, public insurance plays in maintaining the health system.
You have to go first, Tim. I've been speaking.
You mean you want me to defend the medical?
No. We're going to talk about the content. Sorry.
Okay, so yeah, and even the medical profession itself is questioning that. I mean, last year that really extreme left-wing organisation called the Royal Australian College of Surgeons came out and said some of our surgeons are charging exorbitant fees. But, and then the problem is that the AMA is stuck in the belief that they have the right to do what they want to do. Doctors' autonomy is paramount. Even though in a public hospital a lot of their members will be working in a team on a salary, once you get them out of the hospital, they want the right to do everything. Now, I mentioned before that there are constitutional constraints or potential ones on addressing that very directly. But it seems to me that a very obvious way of moving is to fund the public hospital system properly. And to put the money in so that you've got more salaried doctors at attractive enough salaries to do the work. And to do the same in community health centres. I mean, Labor set up super clinics. But what did it do? It said you can negotiate, but basically you can charge co-payments. Now, a lot of them don't. That's good. If they're in the wrong area, they're not going to be able to get co-payments, so they're bulk billed. But they're there. And it was an opportunity to try and move back to the model that Whitlam tried to put in of salary community health centres. In Victoria, we have this system, much better than in any other state. We have a lot of community health centres with doctors. Not all of them are salary, but at least they're controlled and they bulk bill basically everyone. So I think that there's room to manoeuvre, but it takes a determination and belief on the part of the politicians to carry this through within their party so that it can happen.
My name is Bronwyn Walker and I'm from the Young People in Nursing Homes Alliance. And one of the groups that are often missed out in these sorts of discussions are that group of young people who commonly have very complex health needs. And I wanted to raise two items for the panel today, and I don't know that there are quick answers to either. One of them is a recent recommendation that we fought very hard for with the Senate inquiry into residential care arrangements around development of a national rehabilitation strategy, which we don't have. Amazingly, in this country, rehab is still seen as a very expensive and on health service, when it's a fundamental, essential service for many of these people to recover function and regain independence. So that's the first one. The second one is for many of these people who want to leave nursing homes and have homes to go to, we don't have the health services in the community to support them. So if you have a tracheostomy and you need suctioning, if you have an indwelling catheter or you're peg fed, those are very important health supports that you have to be trained to manage. Yet we don't have a workforce in a community setting to do that. So I guess my question is to all of the panel, how do we bring health out of the hospital and into the community in a way that could support these young people to go home and to live really functioning and valued lives that they really want to have but can't at the moment? Thank you.
You're right, there's no easy and simple answer to that, because it talks really to the issue around the interaction of our health system with our disability system, with our rehabilitation system and our aged care system, and it's that we're trying to actually through health reform and through national disability insurance reform, all of that we're actually trying to slowly get towards getting it better. Part of the architecture, though, of doing so was why we set up Medicare Locals. They were charged with not just going out and commissioning services, which I'm worried that the new primary health networks will solely be locked into, is that they were charged with doing a few things. They were charged with looking at what are the population health needs of the communities to which we have responsibility, and what might be the local solutions to doing that, and what partnerships do you form to doing that. They were asked to look at what are the service delivery gaps, whether it is in primary care or whether it is in fact in drug and alcohol services, mental health services, whether it is in disability services, and then what do you start to do, what partnerships do you need to form to actually start to improve those? What are the integration problems between the hospital system, the aged care system and primary care, and how do you begin to trial models that will work? So they were really fundamentally part of the architecture of reform. And I don't think the Abbott government got that. I think they wanted to get rid of them, saw them as a way they could actually get substantial savings. We managed to bring them back from the brink by forcing the Prime Minister in the lead up to the election to say, oh, none of them will close. But then, obviously they've now morphed into these much larger primary health networks. The challenge for all of us now is really engaging with those new primary health networks. I'm not, if we were to win government, I don't want to throw that all up in the air. I think there's been way too much disruption for no good cause, but it is what it is that what we actually have to do is make sure that they still are fundamental parts of the architecture of reform. Work with them in local communities, but we also have to really make sure that nationally within my policy thinking that is part of what we do, and we really charge them to do some of that work. Because it's going to be those that you have to have someone who's actually concentrating on that whole system reform. Yeah.
So I agree totally that Medicare Locals had the potential to address this issue in part. But I'd say there remain two big barriers for it to succeed, very much anyway. It could improve the situation. The first is, once again, healthcare providers and rehab providers and all of those are often paid fee for service, and they don't coordinate. That's a barrier. No matter how good the Medicare rate is in trying to do things, if you've got fee for service, individual practitioners not working in a team, it's really hard to pull them together. That's the first thing. The second thing is, and this is about funding in a general sense, there was this thing that the Labor Party did in its last time called the Gonski Review. Now, it's got nothing to do with health, but what they did was they said, let's have needs-based funding. Well, why can't we do that? Wouldn't that be a dream to aspire to? Are we hearing from the Labor Party that that is what they are aspiring to? I haven't quite heard that message. But if we had needs-based regional funding, all of the pot of money is there to be used in that coordinated framework.
Excellent.
We hear from Catherine on that suggestion.
The challenge again, so again, if you look at, which is why I started with the area of primary care, is there is internationally a move towards patient-centred medical homes where in New Zealand, for example, you have had voluntary enrolment of patients, capitated payments to general practices, work towards the vision of where you might have, in essence they are, community health centres, where you might have the GP at the centre of your care, but you might also then have salaried speech pathologists, psychologists, other primary care practitioners within there. They're community health centres at large. So certainly in terms of the forward thinking of our policy development, that has factored fairly largely, but it is a decade-long reform you're talking about. I think the challenge of moving away from fee-for-service is a very big one. I don't think you can underestimate it, but certainly all of the evidence internationally is the notion of patient-centred medical homes are where you actually want to start to go with primary care. And by their very nature, what that then means is that you are concentrating on patients who have chronic disease and conditions, and if you're going to go down that pathway to develop a unique Australian patient-centred medical home, that is a decade-long reform, and you need a pathway along that. It's not something you could do overnight. It's impossible to do. New Zealand's done some good work on that. I think the coordinated veterans care trials provide a really good marker as to how it might look in Australia, but we're really just starting down that pathway.
And finally, our chair.
Thank you. Very nice.
Thank you.
We've given each of our speakers a Fabian's t-shirt and a copy of our latest pamphlet, What is the ALP's Objective? Which, if you're jealous that they get that and you don't, they're for sale down the back. Which I admit is not needs-based funding, but it is very important for what we do. Can I thank our friends from the North Melbourne branch for helping us organise today's event. And if you've enjoyed today's session and some intelligent discussion about policy, and we need a lot more of it, you should think about becoming a member of the Fabian Society, because this is what we do.